Records.
There we go. Right, that would be a first. Okay. Right. Hi, everyone. I'm John from HDN, and welcome to this webinar today, where we have an overarching theme of tackling the challenge of paper records. And I'm really pleased to be joined by a panel today. We welcome Stacey Sutherland, the Clinical Digital Documentation Lead and Change Lead Trustwide at University Hospitals of Derby and Burton and Calderdale Royal Hospital. We welcome Caroline Holmes, the Deputy Director of Patient Data and Records and Digital Services at Mid and South Essex NHS Foundation Trust. We're joined by Stefan Chetty, the Director of Digital Services at Restore Information Management, and Andrew Robertshaw, the Implementation Manager at Restore Information Management. So thank you to the panel for joining us today. So over the course of the webinar, we will hear from our panel in terms of their experiences and projects in this area. We'll talk about approaches and implementation through to challenges and what has worked well. And then we'll move on to the future and ask, what does the future of managing patient paper or digital documents look like? So the structure of the session, we will start with some wider introductions, then we'll go to a couple of slides to set the scene, and then we'll kick off with some questions that I have, and then I'm also keen to hear your questions in the audience as well. So if you have anything that you would like to ask, type those into the chat and we'll have a look at those as we go. And also we have some time towards the end of the session for a planned Q&A. So I'm keen to hear your questions as well. Finally, the session will be recorded and there will be a write-up done by the HDN team so you can read or watch it back at a later date. So let's get started with some wider introductions. Stacey, welcome to the webinar. Could I start with you in terms of an introduction, please?
Hi, I'm Stacey Sutherland, Clinical Digital Documentation Lead at UHDB and CRH. I'm vastly aiming for the longest job title in the NHS. And essentially my role is all about creating assessments in our new EPR and helping to reduce our reliance on paper.
Fantastic, thank you. And Caroline, what's your role and remit?
Yeah, thank you. I'm Caroline Holmes, Deputy Director of Patient Data and Records. I essentially look after the health records, access to records, clinical coding and data quality across Mid and South Essex Trusts.
Fantastic, thank you. And Andrew, welcome to the webinar.
Thank you. Hi, everybody. I'm Andy Robertshaw. I'm the Implementation Manager and NHS Specialist working at Restore. I've got over 20 years experience of working in information management, with a majority of that time being spent working within the NHS. And what I do is I develop processes and solutions to support customer requirements.
Let's get started. First question, Stacey, where is your organisation up to in terms of managing records, paper records, digital records? Could you take us through where you're up to, please?
Yeah, of course. So we're quite early within the project. A few years ago, the Paperlight project was commenced within our health records team, and they're working individually with teams just trying to reduce their workload and increase scanning. So essentially, they're reducing their storage of paper as opposed to their reliance on paper. But my role is really focusing on the paper picnics or paper to pixels events, as we called it, which we held at the end of 2023, where we invited all of our clinical teams and clinical areas across all 5 of our sites to bring us their paper. And essentially we told them, we can't put your paper into the new wonderful system that we're getting if we don't know about it. And essentially we said, bring us your paper, we'll process it and we'll get back to you when we're done. So that gave us quite a lot of information and quite a huge challenge in doing it. But now the task is to sort of process all that paper and make sure that the right forms are processed in the right way and put into the right system at the right time.
Fantastic, thank you. I think I saw a picture on your trust website of the Paper Picnic project. How many documents or different types of forms or templates did you have?
So I think we gathered just over 3,000 documents altogether, and there were over 1,000 individual forms that were logged, which was even more than we ever expected. But our biggest shock was that 70% of those were not trust approved documents. So we always, anything that's approved has a barcode on it for scanning and things like that. None of them had that coding that we used to use or anything like that. So, you know, a massive, like that's like 700 individual documents that are going into patients' paper notes that nobody knows about. And essentially that could be that this one form is the verified one, but this ward has chosen to put an extra column on it or an extra field on it. So then they're printing their own. So the cost implications are huge, not only of like storing the paper, but of printing all that and ordering the paper and things like that. So it really was a massive shock to sort of everybody that was the amount. Because I think as a nurse, I kind of sit there, it's only one piece of paper, it's fine. But now working here, you kind of go, actually, this is a huge impact to thousands of people at once. So it was quite big.
That is interesting. It would be great to go through that in the session in terms of your approach, your learnings, what have the challenges been and how did you tackle them? So we'll get to that during the next hour. Caroline, can I come to you next, please, in terms of how is your organisation managing paper digital records from 5-10 years ago up till to now?
Yeah, certainly. We've done similar work to Stacey's just outlined, but I'm going to take it more from a health records perspective in terms of managing the health record. Just as COVID kicked off, we merged 3 acute organisations into a single organisation where we've got over 300 electronic clinical systems, of which includes 3 legacy PAS systems. So there's a lot of information that's held electronic, but there's also a lot of information that's held on paper still across the trust. While the Health Records Department itself has got a single management structure, each individual site still has a legacy PAS system and therefore separate patient IDs and therefore kind of different processes that we've inherited across each site. So I've got one site that's pretty much kind of 95% scanned and has been for about 10 years. I've got another one that all outpatients are scanned and have been for a number of years as well, but only about half of the inpatients are scanned. And then the third site is recently embarked on its scanning journey and was probably about 2% scanned this time a year ago. And we've now managed to get that to about 50% scanned. But recognising, as Stacey said, that scanning is not getting rid of paper, it's just the storage of it. And that's where we there's this kind of myth, isn't it? Once it's scanned, it's digitalized. It's still very much relying on paper and the costs associated with that. But within the trust, we're embarking on an electronic patient record at the moment, due to go live in about 18 months' time with a neighbouring mental health and community trust. So it'll be one single PAS system or one single EPR across both organisations. And that's where we are at the moment. So a lot of the work we're doing is to make the precursor, so scanning information to make it more visible is very much a precursor to us going live with the EPR.
Fantastic. Thank you, Caroline.
Okay.
My colleague Jenny, could you load the 2 slides we have, please? So hi, Stefan. Welcome back. We've just covered some context and background information from Stacey and Caroline in terms of their organisations. So if you could provide a bit of an introduction in terms of yourself, and then the couple of slides in terms of setting the scene and context that we have here. So over to you, Stefan, if that's okay.
Sure. Thanks, John. Hi, everybody. My name is Stefan Chetty. I'm the Director of Digital Services at Restore Information Management. Didn't hear the intros, but just as a summary, Restore essentially help organisations, predominantly the NHS, with all elements of the document lifecycle, from creation, data capture, storage, retrieval, and transport, physical records. But our primary focus really is around helping those trusts to create and execute a plan for going digital. And then we deliver those services as well in terms of the standardisation of the content of records prior to digitisation, scanning of paper records, hosting of metadata and images, right through to the secure and compliant destruction of the physical paper in line with retention periods. I've got a couple of slides. It is only a couple of slides just to set the scene on some context around what we're seeing in the marketplace and also what the NHS are telling us. So Jennifer, if I want to move on to the first slide, please. So I won't read through all the detail here, but the numbers kind of speak for themselves. So this is whilst, you know, in Andy and my experience in particular, no one trust is the same. There are similar challenges and themes that emerge. And I'm sure that will come out across the conversation today. But this is a consolidated view. For those that don't know, the ERIC data is the estate's returns information collection, which is information published by the NHS every year that tell you about some of the costs and space used by trusts. And what that's telling us on a consolidated view is that there is still a significant spend on storing medical records, typically paper records, which for those that aren't directly involved with health records might be quite a surprise, because there is obviously a huge drive within the NHS to go digital, right? So, but we see the on-site cost there across all trusts. This should qualify non-ambulance trusts. Of the 199 that complete the survey, that number of 178 million has actually increased since the last survey was done by just over 4%. So that's an on-site cost that's increasing over time. And there is still an off-site cost there, which makes up about 27% of the overall cost, which has slightly decreased, but broadly stayed the same in that time. So there's obviously a cost challenge there, but also that for those of you that work in the NHS, you'll know about the space challenges that presents as well. And again, I won't read through all the numbers here, but that number of 220,000 square metres taken up by medical records on sites at hospital premises is significant. And again, a number that has grown in that time, at a time where arguably space is more of a premium than ever within the NHS. So the paper records themselves that do exist are still very prevalent at trusts, do create their own challenges. And what the data also tells us is that the vast majority of trusts are in some way, shape or form still reliant on paper. You can see there that's quite conservative, 75% of trusts still have a reliance to some degree on paper. Now that will vary quite considerably across trusts, but there are only 4 trusts that are bold enough to say they have gone fully digital, which as a percentage you can see is fairly small. So still a paper challenge within the NHS that needs to be looked at, and each trust, as I'm sure we'll come on to, is at various stages. But what really does that tell us? There's a real opportunity for cost savings here. There's a real opportunity for estates rationalisation and digitisation of records to try and reduce that pressure on the trusts. And there's an opportunity to prioritise capital projects that are linked to patient care. And also it does create that chance for redeployment of resources to frontline care, which is much needed. The next slide, please, Jenny. And this is a little bit, again, I won't read this word for word, a little bit about how Restore support, because our main focus is within the NHS. We can immediately release space savings and costs through off-site storage. That can be done even prior to going digital, and is often kind of best way to release that cost in the short to medium term, even if a trust isn't quite there with going digital yet, because there's some immediate savings to be made. More importantly, when it then comes to digital as well, we can support you on that journey. So whether that's the scanning of newly created paperwork, if you are still creating paper, and the standardization of what that looks like, digital delivery as opposed to physical delivery. So where there is a reliance on paper now, that can be turned in the future to a digital delivery. So you've got the information digital at the point of care, and that's a change that can happen over time at the time it's right for the trust. We're system agnostic, so can integrate with your chosen EPR and EDRMS suppliers to deliver that information into. And we can also, and we do also integrate with your PAS systems to create auto ordering systems. So where you may have an admin overhead of requesting physical files from either an outsourced provider or from your own internal health records team, we can provide an interface with your PAS system that automatically delivers physical or digital files at the right time for the clinic in advance of appointment. And that's all underpinned by strong governance and including compliance to the NHS Data Security and Protection Toolkit. And then as we transition to digital, ensuring that any digitalisation is done in line with the correct accreditations, including BS 10008, which is the accreditation for legal admissibility of a scanned document. And that's all I had to cover as a summary on that.
Fantastic. Thank you, Stefan, for setting the scene. So keen to drill into this in more depth. The very interesting stats. We've spoken about physical and digital and managing those. So let's move into talking about approaches and perhaps prioritization as well. So Stacey, can I talk about your trust or your group of trusts? Like, how are you approaching managing paper and digital records? How are you approaching prioritization? So you spoke about thousands of different types of documents. Where do you start with that? How have you started with that?
It's still a question that I'm trying to answer. Essentially, we're just starting the single EPR journey. So we're very similar to Caroline's Trust in the sense of the University Hospitals of Derby and Burton were two separate trusts up until 2017 when we merged. So we're still trying to get all of our systems into one. And I think the way that we've really looked at it, it's almost been dictated by the EPR as to what they can deliver at what point and how things flow. Essentially, we've had lots and lots of different ideas of how to do it. So some of it has been dictated by, okay, we're turning this system off. What is in that one? Let's get that one in first so we don't regress. Because obviously we want to keep our HIMSS level as high as we possibly can. But essentially, we're looking at this from the view of the patient more than anything. So I would like things recorded in the system that, it sounds quite crude, but things that go in and out of the patient. So things like any cannulas, any chest drains, any fluid balance, that sort of thing is a really high priority for the patient to make sure that we're recording things really properly and that they're really auditable. But equally, from a patient's point of view, they want one person to know their entire story and they don't want to have to keep telling it over and over. I think we've all been in that position as a patient where you go to your GP, or even before you get to the GP, you ring the receptionist and you tell them your story, then you see the GP potentially, and you tell them your story, then they refer you and you tell them your story, then you go to another department. And before you know it, you're bored of telling it and you've forgotten half the stuff. So actually, if we did have that one record where everything was recorded, I mean, I know it's very blue sky thinking. I like to be like, let's be future, let's think outside the box, and be realistic in the sense of that is what matters. And I know stories that I've had with people where they go, you're too reliant on computers, let's just go back to pen and paper, you know, my mother-in-law and my gran and stuff. And I go, but how nice would it be to not have to tell that story over and over? And they go, actually, you're right. So, you know, it just proves to people that there is a place for this and how important it is. And that's how I'm trying to be very much patient-led, but equally looking at our clinical teams that are the most reliant on paper and almost starting at the beginning of the patient journey flows through for the patient and for our clinical teams as well. And I think by selling it to our teams as well in that way, they're kind of agreement with it, because we do have a lot of old school doctors and nurses that learnt on paper. You know, we've got that semi-field of people that learnt paper and that people that have never seen a paper drug card or a paper observations card and things. So actually selling it to them in that way as well really does help. So that's how I like to think that we're going to do this, that we are doing this in that way.
Great. Thank you, Stacey. And Caroline, from your organisation, what can we go into your approach? What's worked well? How have you prioritised?
Yeah, sure. A lot of it's kind of mirrored by what Stacey said, but we're very much trying to standardise where possible the approaches across the three legacy organisations. Although that comes with its challenges, because we've obviously got legacy electronic systems, either to store the kind of PAS data, but also we've got legacy scanning systems at each site as well. So knowing we've got the EPR coming, we're choosing not to change that process at the moment, but that does each one of those systems has got its own challenges, and the granularity of how we can record stuff is different to each site. But very much we are trying to standardise documentation, particularly the nursing, maternity, and AHP documents, to try and make them consistent across the organisation and visible. As Stacey said, we also found a lot of oh, you got a form in this specialty, have you? That's nice. No one else knows about it, but we're using an external scanning company to do our legacy scanning for the site that's just going through the process now, and that's working really well, where we send all the old information off to be scanned, and then day forward stuff we're scanning in-house as consistent across the other sites. I think Stefan touched earlier on the storage. We've why would we have the same processes, but we've one site had very little activity on storage actually at the on site. One site has about 12 months worth, or did have about 12 months worth of activity. That's really reduced down now because of scanning. And another site has got a huge warehouse, effectively with about 5-6 years worth on. Once we don't need those records anymore in their physical capacity, so once we haven't kind of got the space, it's more a case of we don't have any more space on the shelves to store anything else. What are we going to cull or move off site? We send them to an off-site storage facility, which happens to be Restore, and they manage those off-site storage records. But when we call them back now, we're starting to scan those rather than send them back to deep storage. And we're also, once we scan the actual record, we're destroying it after a month. So that's QC'd the quality. Once the quality is adhered to, we then destroy those records after a month. And that's the same with our off-site storage company as well. They also follow those same protocols. But the main thing is around standardization and accessibility, for not only for within the organisation, but we've got an acute care portal, which is an in-house written piece of software that clinicians within the organisation and beyond the organisation can view in one portal. I mentioned that we've got about 300 different clinical systems. A lot of those are visible via this acute care portal, and that includes the scanned health records. And GPs have access to that, and colleagues in the community, not just within the trust. So patients moving across sites or between agencies, that information is visible to people as well, with obviously the right permissions.
Fantastic. Thank you, Caroline. And Andrew, can I come to you next, please, to hear your views on what we've spoken about so far? And you obviously have a wider view in terms of visiting lots of different organisations across the country. What's your advice on how to get projects like this right from what you've seen? So a couple of questions there.
Yeah, so John, thank you for that. Yeah, it's been really interesting actually listening to Stacey and Caroline already, because actually a lot of the approach that we take are actually very, very similar, and actually we would work together very well, really. I suppose I've got 4 key areas I just want to quickly touch on for the sort of successful delivery of a project. And this could be a project that's managed completely in-house. It could be one that's outsourced, or it could actually, like Caroline just said, be a combination of actually working, doing some processes yourself and outsourcing others. So my first area is planning, really, and it's been really good to hear, particularly from Stacey, around this. So it's understanding where you are now and where you want to get to in the future, and these are big changes that need to take place within organisations. So it's just really understanding, what do you do with medical records now, and how are those medical records used, and where you want to get to in the future. It's also worth considering timelines and approaches. So, with some of these projects take a significant amount of time, but also planning on how you're going to phase those changes in. So are you going to go with a sort of a phased approach, maybe a speciality by speciality or site by site, or is it going to be more of a big bang and everything changes up sort of overnight? Critical to me then is producing a gap analysis and a project plan. So be able to really take you from where you are now to where you want to get in the future. My second area is communication. So obviously there's got to be wider communication within the medical records team and the wider trust. But actually early engagement we found with influential clinicians is really key to get these projects going and to keep momentum going. I think it was Caroline that said some clinicians will have only ever dealt with paperwork and maybe really reluctant to change. And actually what we found is if we get those guys on site, they'll talk to their colleagues and they'll talk around the hospital and actually get, beyond the side of the overall project rather than hindering that project. My third one is standardization. I'm really pleased that's been talked about quite a lot already. For me, it's getting your current medical records in a good state, ready to go digital. So that could just be from the physical size and layout of it, or it could be to reduce and standardize the forms that are going into it. That will always help in the future with digitization. It's also worth considering how records are accessed and used today. And what I quite often find is some real differences in how medical records are used within the same hospital, how far in front of an appointment they're delivered, how a referral letter is attached, for example. And then my final point on standardization really is just really consider new paperwork and e-forms. If you can stop the production of paper in the first place, that's great. And my final one is just work with a trusted partner. So, and this forum's great, really, isn't it? So a trusted partner could just be somebody else within your organisation. It could be another hospital that's already done something, or it could be a supplier like Restore that's got a wealth of knowledge. Don't work in isolation. Somebody has already probably done or tried or had an idea of what you are planning to do. Talk to those trusted partners, get their advice, but also ask them what hasn't gone well, what they maybe had to backtrack on, and don't fall into the same traps. Really.
Great, thank you, Andrew. So to pick up on some of those points, one being how far before an appointment the records are delivered. How does that work, Caroline, in your organisation? Because Andrew suggested that could change in terms of the timing.
Yeah, in terms of the actual kind of delivery of the physical health records to locations, we got people that deliver those records around the trust for outpatient appointments. We still have to deliver, we call them orange wallets because they're orange, but we still have to deliver the kind of, I guess, kind of paper, blank paper and the labels to the outpatient departments. But obviously they're a lot smaller because they don't have the historical information in them. So a clinician seeing a patient in an outpatient appointment at the moment, certainly at the site where we're transitioning, we'll see a mixture of patients with physical health records and those with scanned health records. Tracking is notoriously dreadful at the trust. So actually trying to kind of find the health records to be able to deliver to a clinician is a challenge because quite often you have to pay detective about where they may be located around the hospital, so we can actually provide them for that care. And quite often now, unfortunately, we're finding they're going between hospitals because the patient's being seen at a different site, and because not everybody at every site had access to the host PAS system, they're not always tracked and they're off-site somewhere at another hospital. So not only are we now playing hunt the record within the footprint of the main hospital, but also potentially it could be off-site at another hospital as well. So lots of challenges around the moving of physical health records around the organisation.
Stefan.
Yeah, just to pick up on that point that you mentioned, I mean, that is a huge benefit in looking at it as we are today and moving to a digital solution. We've seen all sorts over the years, but that challenge of notes retention around a hospital or a different hospital as it may be, we've seen cause real challenges. In some cases up to 30% of notes required for clinic have been somewhere that wasn't the medical records library, i.e. either outsourced or insourced somewhere around the hospital. So then you get the challenge of temp notes being created, as I'm sure you're aware. So you've got two versions of the truth. Then if your clinic prep processes don't merge those two, then you could end up having the most important information in a record that isn't seen as the primary. You've got loose filing separately to come into that as well, which if in a digital world is taken care of if you're set up in the right way. And then, as you mentioned, Caroline, you've got the intersite transport, which typically do have an agreed SLA, but sometimes not. So that all contributes to it being a challenge to get paper records to the end user at the right time for the appointment. And I guess one for it's great to hear about trusts that are much closer to going digital and are about to implement EPR. That's kind of where trusts want to get to. The challenge is there's still quite a few that aren't quite there yet, and it's not widely spoken about, I'd say, but like they're going through those challenges, even including notes of, significantly larger notes than you'd want to if they're not managed through the clinic prep process. So you're sending out information that doesn't need to be handled. So that standardization of processes, but also content of a record, can be done even if you're not ready to go digital, so that it does then help you to go digital in future. So if there are certain things that can be put in place to control how that information is used and managed, and what goes into a file, so that when you do come to digitize, if you do come to digitize, you may not, that scanning is far more straightforward. Even included in a barcoded form as part of the clinic prep process, and standardizing your forms now rather than when you're about to go digital. There's a lot of pain that could be taken in the immediate future to enable a swifter and more cost-effective, frankly, digitization program in the future.
Thank you, Stefan. Stacey, can I come to you next, please? And I think I have a couple of questions, really. The first being your views on what we've spoken about now, and then a couple of questions from the chat. One being, who did you have as key people in your project team? And are you progressing to using e-forms and where records can be supported by decision support, prompts, next steps, contextual advice? So a couple of questions there, I'm afraid.
So I think the key people in the project team is never fixed. Having a good project manager is obviously key, because we need to be kept in line and have the right communications and things that are going out. But I think we call them subject matter experts, and for every form or everything that I consider, we have an expert from that field. So I don't class myself as an expert in anything, really. So at the moment, if I'm creating a hydration form, I've got my kidney, my renal nurses and things there. If I'm creating the musts form, I've got my nutritional steering group there. I go to the leads for that department and say, right, who do you want involved? Who are these key people that I need to make those decisions? At our trust, we have patient safety group, who are key decision makers throughout the trust, and also having executive buy-in is a massive part of this. So, excuse me, the decisions being made at the moment now, we've got a 68-page booklet that is purely assessments and care planning for our patients. How are we taking stuff out of there? How are we saying this is now on our electronic system and not in this booklet? That's not my decision to make. That's our chief nurses that need to be making that decision. And so actually having really, really good relationships with all of them has been key to all of it. And I think getting that buy-in right at the beginning, and when we were generating the excitement about choosing our new EPR and getting paper to pixels off the ground, I hate to say it, but goodie bags with sweets and pens really were the future of getting people buy into these projects. We're going electronic, but please have a pen, was the future of what works. Unfortunately, it's the NHS. This is what makes us roll.
Fantastic, thank you. So can we move on to talk about data governance, protection, compliance, in terms of how is best to approach projects like this from a compliance perspective? Perhaps, Stefan, could you start, and then we'll go to Caroline and Stacey.
Yeah, sure. Yeah, thanks, John. It's a big subject, so let's be honest. But the foundations are there. So you've got the NHS Data Security and Protection Toolkit, which does outline, a lot of the things that need to be considered. It's, I guess, just the practical application of that that's open to interpretation in some cases, but it does cover, GDPR, core principles, how, what you should and shouldn't do around FOI and subject access. But if we're talking about the paper records in this instance, the governance and compliance of those, it's a lot of the things we've already spoken about. So, what's the data capture like? Is your metadata consistent? And in the right format, your volume control, etc. Your tracking, your audit trails, your processes, the file content. Is it complete, consistent? Are you making sure that all the right information is presented to the clinician at the right time, which is much more of a struggle in the paper world than it would be in a digital world. But then you've also got compliance around your physical and logical security, and the condition in which the files are stored. Any business continuity, but the people compliance and training, awareness, recruitment, press training, system compliance, not just IT. We've got management systems, quality, business continuity, risk management, and maturity measurement of that. The way that we have done it is that we've developed a certified information governance framework that's based on the NHS DSP and takes into consideration the NHS Records Management Code of Practice, and it essentially helps us go through customers, and particularly ones that are a bit further away from going digital, those things that Andy referenced earlier on. So really understanding the current state, understanding the objectives and the timescales that the organisation is working to, and then producing a gap analysis of that, and then helping the trust with an action plan of how to bridge those gaps in an appropriate timescale for them, which will look different to different trusts. And that will cover your physical, logical security, your process, risk management in line with DCB 0129, clinical safety, operational resilience like business continuity, and ultimately your digital readiness and your action planning, including BS 10008. Included in that is also a stakeholder management plan as well, which is again great to hear. That's already been spoken about as a key way to make sure you do have that governance and buy-in around the trust, ultimately as a key part of you achieving the HIMSS level 7, which is the utopia of trust. But that's the way that we approach it, with the framework that we've developed off the back of the foundations that are in place within the NHS. It's just the practical application of how to use them is a thing that some trusts struggle with.
Thank you, Stefan. Stacey, how have you approached governance? You have multiple sites. Have there been any challenges in terms of that, different types of documentation, or?
Oh gosh, yeah, there's loads. Absolutely loads. I don't think it'll ever resolve itself easily, and I think just trying to get buy-in and agreement from everybody is a huge thing. But I think it really depends what you class governance as, because to me governance is the process around how decisions are made and how we store that information, how we record that information. Because like we're looking at our old systems now, and one of our systems, one of our EPRs that we've got in has been in for 30 years. And actually trying to find how those decisions were made 30 years ago is quite a challenge now. We're really lucky that we've got teams that we can click on record, and it gives us all these AI generated notes for our records now. We didn't have all that back then. And if that note taker didn't choose to write that down, then we haven't got that anymore. And that's what we're trying to do, is that once that process is in place, is making sure we've got that record of that is stored in a central location for everyone to access. But I think the main thing really is actually making the clinicians and all of our clinical colleagues realise that actually they may think that this one form that they use is generic, bespoke to them. But actually, 90% of the documentation that we do when a patient is admitted, for example, is the same. It doesn't matter if you're gynae or surgery or medicine or wherever you are. It is the same. We're asking the same questions, and having that one form actually is going to make life so much easier for everybody. And that's kind of how we're working with it, is going, actually, let's condense this in. And actually, if we just have to put one extra question for that speciality, that's what's going to help. And then just making sure that all those decisions are recorded in a really suitable way is really what matters.
Mm-hmm. Have you had it where Chesterfield have a document, Derby and Burton a similar document, like you say, 98% the same, 2% different?
Yes.
How do you manage that?
So I find rewording is really, really helpful. And essentially, there are some things we have to accept that we are different trusts, and we have different legal teams, we have different requirements, and some things have to be accepted that's always going to be different. But we are working as part of the it's called EMAP, it's the East Midlands Acute Providers, and it turns out purely by chance that quite a lot of the East Midlands are now choosing the same EPR, and it was never done intentionally this way, it's all happened this way. So we are now saying, actually, why are we all documenting different things? If I transfer my patient to a neighbouring trust, I want to be able to send the paper with them. I don't think that nurse should have to restart their care plans and things like that. And if we start from the same place, then we might actually be in a position to do that. But equally, I want to know that when I go on holiday to Newcastle or Morecambe or wherever it is, if I go into hospital and have an allergic reaction to something and then come home and get admitted here, I want my doctor here to know about it. Why shouldn't the NHS have this sort of information that is combined for everybody? And I know that I am very much like, let's change the world, but I think you have to have really, really big ambitions if you're ever going to get anywhere with it. And nobody will ever change anything if we keep going, it can't be done, let's just stick to what we know. We have to really fight for what we want.
Yeah, I don't think that's an that's, I think a lot of external people would think that was in place.
Exactly. And I think if I can log on to my Amazon and put in a search word and get the same answers that you do when you log on, that's possible. So why isn't it possible to share our information? And I respect that some people don't want the fact that a doctor in Scotland can go in and see my record, and that's absolutely fine. But equally, I want to know that people know about me. If I'm on a road trip and have a car accident, I'm unconscious, I don't want to be given what I'm allergic to, and things like that. It's not huge. And I think if we put all the right governance in place and if we have the right ambition, then we can get to these places.
Absolutely.
I'll be Prime Minister in a few years and we'll sort it all out.
You'll get my vote, Stacey. We've had a couple of comments and questions in the chat around retention. So, Caroline, can I come to you next, please?
Yeah,
if
sure.
there's anything you want to add around compliance, do so. And then the retention questions in the chat around. Yeah.
I think just the only thing to add to compliance to what my colleagues already said was around the ability to audit who's viewed a record with making them electronic, whereas when they're patient-based, we can't actually see who's looked in that record. And no, that's not kind of something we do routinely. We have had examples where either staff members or patients wanted to know who's accessed their health record, and with the ability to audit trail electronic information, that's been something that's been more useful rather than just saying it went to a department or it went to a ward, or if it's even tracked and we know it's even gone there. So that's another kind of governance benefit of not having the paper records. In terms of retention, I was hoping no one would ask me anything about this, but never mind. I think the reality is, I saw kind of Kathy and Elaine's questions. The reality is, within our organisation, we haven't destroyed anything for a long time, purely because of all the inquiries where we were the Utri inquiry. Then there was the infected blood issue as well. So we haven't actively destroyed records in recent years unless they've been scanned. So that's the kind of approach we've taken. We appreciate we're breaching everything all the standards at the moment, but every time we've tried to put in a process to start destroying the records, something else comes up that stops us them doing that. I agree with the comment around the what do you declare class as a long-term condition. There's other things in there as well which are really ambiguous and don't lead us to trying to identify those records as well. It's not easy to identify which patients, when we can destroy a certain patient's record. If they're deceased, that's easier obviously to identify. If they've had joint replacements, how do we indicate that patient's record needs to be kept and doesn't? It's not an easy thing just to say destroy everyone that hasn't been here within so many years, because that varies on so many different categories where we have to make a decision, and that's really intensive. Someone's role to do that. I think I once worked it out that if we were to try and destroy everything within our one organisation at the time I did it, I think it would take one person 60 years to go through and agree whether to destroy it or not. So we're just taking the approach of scanning it rather than which again, just because it's scanned doesn't mean to say it doesn't exist. And that's another kind of challenge as well. So sorry to be not much use to the people that put questions in the chat, but we're not dealing with it within our organisation. Rightly, wrongly. I mean, definitely wrongly, obviously, but every time we've come to try and do with it, there's always been a directive to say don't destroy anything else. Mm-hmm. And I think that's a key thing around EPRs as well. Just because the information is electronic, how do we put in automatic destruction criteria into that as well? Because the record does still exist, and we should still be following the right rules and retention policies for those as well.
Andrew, can I bring you into this, please, in terms of your views on what to scan, what not to, and retention and destruction policies? What's your views and best practices?
Yeah, so just adding to what Caroline said around the destructions, what Caroline's described there is pretty typical of most of our customers, where they're struggling to make the decision that something can be destroyed. We are starting to see small pockets where destructions do take place, but typically not with most organisations. On the what can be scanned and what can't be scanned, I suppose again, or what should be scanned and how do we make that decision? Again, that very much comes down to individual organisations and what their approach to scanning is. I think I'll just touch on the bit Stefan said right at the beginning around our automatic ordering system. So we can take a live feed out of your PAS systems into our own system and use that to make decisions on what should be scanned. So, for example, some of our customers scan to appointment. As long as the appointment is made more than so many days before the patient's seen, to allow the time to scanning. If it's not and it's a short notice appointment, it may still be a physical record that gets delivered. Others switch on scanning by speciality or clinic code, and that can be done as well. So there's various different ways, and that's sort of my job really when I'm working with a trust, is to come and work on what do you want, what has worked in the past, what is best practice, and actually let's work together and work out what we could do.
Thanks, Andrew. Caroline.
Yeah, just coming in on that round, what to scan and what not to scan. We started off by scanning by specialty, and then very quickly it became more time consuming trying to identify the records from within the health records library that should go off. We started doing new patients that were new to a specialty, and very quickly kind of that patient then came back to another specialty. So it kind of spread across the organisation that the clinicians were dealing with paper and more electronic records. Then we then took a decision to basically do it by terminal digit number. So most health records libraries are filed by terminal digit. And we literally just we run a report each day that says these patients don't have a scheduled appointment or TCI within the next 30 days. And then we pull off about 1,000 a night at the moment that get sent to our offsite storage, our offsite scanning company, and they scan them that way. And then if similar to as Andrew kind of implied, that if we then need them urgently, we can get them scanned within a couple of hours and they'll get prioritised. So to reduce the kind of risk clinically. But it was just easier for us just to basically pull off every other file or something in a block of storage. We have had issues with certain pockets across the organisation that are struggling with the scanned approach, and particularly with the fact that we scan them as we receive them, so we haven't got time or the inclination to go through and make sure they're all in date order, they're all up the right way. And the bit they're struggling with is that we're literally kind of scanning them in sections. We've got an inpatient section, outpatient section, and communication section as the physical health record would be structured. And a lot of the noise we're getting at the moment is around, well, I can't find it, it's out of order. Well, you file it right in the first place. That's a bit kind of, you file it right in the first place and it wouldn't be out of order. And by the way, there are search functions that you can search for keywords if they're, for certain things in there. And it's about the, I guess, the training of the electronic system they're using to access that information as well. They're kind of moaning about the process of scanning the records, but actually it's more around making them aware of the functionality within the system they're accessing those records, and that kind of one-to-one aftercare and floor walking and things like that has proved invaluable as well. But we are still meeting a lot of resistance.
Yeah, I mean, just to reiterate Caroline's point there, that going back to what I was saying earlier, that that's why, especially if you're a little bit off going digital at the moment and you plan to scan, getting your physical processes right can have a huge influence over how effective your scanning process ends up being. So clinic prep, making sure things are in the right place, but even the file size management, because if you haven't managed, standardized file sizes over time and create new volumes when you get to a certain thickness, for example, then what to scan can be a completely different decision, because you don't want to scan all the legacy paper that's not necessarily current. Whereas if you've managed your records over time, then actually that what to scan decision may be easier to make. I'm not saying it's easy to make, but it makes it a bit easier.
We just scan it all because we have no structure and no historic order to it. So yeah, we can't expect a band 2 health records clerk to make a decision around what to scan and what not to. So if it's made it into health records, we scan it, and sometimes we have someone's printed off a document and shoved it in the notes. Maybe the same thing would be scanned 2 or 3 times because there may be one thing different on it, and we can't take that risk. But yeah, it doesn't equally lead to a lot of duplication, and then it makes it harder for clinicians and others to access that information.
Yeah.
So we've had a question come in about indexing, and the question is any use of OCR for indexing, and any thoughts on combining natural language processing or AI to help with that process. I think to answer that question, is there an opportunity to automate some of these processes, and potentially how is that being done? Can I start with you, Stefan, from a technology perspective on that one, please?
Yeah, so the use of OCR is fairly standard in our scanning, but the use of natural language processing is something that we're developing at the moment. So I literally got the call before this one was just about that very subject. It's just the sources of data within medical records specifically is more of a challenge. Again, it comes back to how have the medical records been managed in the physical world to enable to train the models to deliver the outcome that you need. But ultimately, the use of natural language models and AI will be a key thing to how the NHS develops. A lot of it will be how newly created information is used, but because of the lack of standardization in the format of the physical medical records. But absolutely, as much of that process is automated as possible.
Fantastic, thank you. We've got a question in about mental health records. And so, Andrew, could I come to you for this one, please? Are any just scanning mental health records, but the question is more about what has been your experience in that? Is there anything that you could share with us from any of the organisations you've worked with?
Yeah, so we do scan mental health records. I think one of the challenges with mental health records has been the geographical location of these. So they're not typically all held within a central medical record library and can be controlled. They are often held in small and local stores around the organisation, and that does bring the challenge. It's a challenge about then getting the right patient information to be scanned and making sure you've got the whole the entirety of a patient's medical records as well.
Fantastic, thank you. I think so far we've covered most of the questions in the chat, so thanks to everybody for
John,
asking.
sorry, there is another question in there, sorry, and just above the mental health one in the same chat around the visibility of legacy patient records in the EPR. Our approach to that is to have an archive solution as well, where the plan, if it comes off, the plan will be to have a contextual link in the new EPR. If you want historic information, you click the button, it opens up that patient with all the legacy information from the multiple PAD systems that will be merged. So that's our plan, is to have hopefully a fairly seamless archive where you can then see the historic patient records that have been scanned, plus test results, plus information from other systems as well, but to have a kind of contextual archive.
Mm-hmm. Great, thank you. Another question around retention. How have you addressed challenges around retention when the source data is for clinical research purposes when converting case notes? Do you want to take that one, Stacey?
Yeah, I was going to say this is something that came up quite a lot when we were doing our procurement process for our new EPR system. And I don't think you can answer it easily because it has to be included in part of the research project that they are willing to have electronic records and electronic signatures as part of the requirements for a research project. And I know that I've got quite a lot of very close colleagues that work within research, and they are so avidly this has to be right, and you can't do this, and we have to have that, and that's why I would never give a generic answer to something like that, because it would need to be specified in the actual research project itself. Personally, I go, why can't we treat it like anything else and create your bespoke stuff and things like that? But I think a lot of it could be a lot of work for very little benefit when you've got a research project that maybe the recruitment of patients is only open for 30 days and things like that, and what happens to that further down the line. So I think it would need to be looked at with each individual research case.
Fantastic, thank you. Right, so we're coming to the end of the webinar. We've got 3 minutes. So can I ask you all for a final key takeaway, perhaps what you think the future of this space will look like, but one thing you'd like our audience to go away with? Stacey, can I come to you first for that one, please?
Oh gosh, it's a really hard question. What would I like anyone to take away? I mean, going in my non-nursey head, I'd go, let's aim for the big picture. Let's, save all the trees and never print anything ever again. And I think the only problem with that is that we need to be realistic, and we need to make sure that we have all the right people involved in the decisions that we make and make them for the right reasons. And essentially remember that digital isn't always the answer. We have to make sure that we have the right process in place to get the digital system right. I think that's possibly and if sometimes paper is the answer, really, and that if that's right for that process, then that's what needs to stay.
Great point. Andrew, can I come to you for a key takeaway, please?
Yeah, so it's something I've spoken about earlier on, but it is working with a trusted partner. It's clear just in this conversation we've had today, there is an absolute wealth of knowledge out there and experience. So it's don't work in isolation and use other people's experience to support your project.
Fantastic, thank you. Caroline?
Building on Stacey's really around if we are going to use paper, and I agree, absolutely agree, we're never going to get rid of paper, but making sure there is the ability to combine that paper, scan that paper, whatever that might be, into the mainly digital record, and to try where possible to make sure things are entered at source so we can start removing the paper, because it makes the information much more accessible to everyone involved, including the patient. We're trying to kind of improve the patient's accessibility and visibility of their own health record as well, and that's so much easier by the digital world.
Great, thank you, Caroline. And Stefan, same question to you, please.
Similar theme. I think if you're planning to go digital, which all trusts are in some way, shape or form, maybe for those ones a bit further away, make sure that you consider paper in decision making, and you see that paper is part of the solution rather than part of the problem, and frame it that way. Because if you are struggling to get the complete paper record to the end point to a clinician, then you will struggle to do that in the digital world as well. So make sure your processes are right prior to then digitisation. So when you do digitise, then that information is complete and standardised. It will make things, it'll make your EPR far more complete and standardised.
Fantastic, thank you. And it's 12:59, so we're perfect on time. So I'll look to close the session here. I'd like to say thank you to the panel for taking the time out of your busy day to join us. And I think it's been a really interesting session, and we've covered some really good practical tips there. So I hope everybody in the audience has found it useful too. Like I mentioned at the start, there'll be a write-up so we can share some of the key themes. So it's something you can digest and reflect on outside of this session. If you have any questions that come to mind, I can help connect you with the panel. My email is john@htn.co.uk, so feel free to email me any questions. And it's just 1 o'clock, so I'm going to have to close the session here. Thanks again to the panel. It's been a pleasure, and have a nice day, everybody.
Thank you.
Thank you. Bye.
Bye-bye.
Thanks. Cheers. Bye.